Hello and welcome everybody to Alumni Reunion. My name is Dorina Landa and I am the Executive Director of Advancement at the Temerity Faculty of Medicine here at the University of Toronto. And I am so pleased to welcome you to our annual Stress-Free Degree Lecture Series. Before we begin, I would like to take a moment to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are truly grateful to have the opportunity to work on this land. Whether you're joining in person or online, we hope that these lectures will provide a great opportunity to learn from some of our leading faculty members on important, relevant, and certainly current topics, but without any of the homework. For those of you joining online, we welcome you and encourage you to ask questions using the Q&A function, which should be on the right-hand side of your screen. Now, before we begin this stress-free degree, I would like to take a moment to introduce our speaker, Dr. Juveria Zaheer. Dr. Zaheer is an assistant professor in the Temerity Faculty of Medicine's Department of Psychiatry and a psychiatrist and researcher at the Centre for Addiction and Mental Health here in Toronto. A nationally recognized expert in suicide assessment and prevention, Dr. Zaheer focuses on developing and evaluating targeted suicide screening and prevention strategies. She serves on the board of directors of the Canadian Association of Suicide Prevention and was recently named among the top 40 under 40 in Canada. So please join me in welcoming Dr. Zaheer.
Thank you so much for having me here today. I know that this doesn't feel like a stress-free topic, but it is my hope that we focus on the hope. And I hope that this is an optimistic talk that brings us closer to a future where every life is worth living. It's such an honor to speak with you today, both here in person and online. Events like this make me think back to September 2000, where my brother and sister and my dad dropped me off at New College in the Wilson Hall building. And my brother and sister, they hid in the closet because they didn't want to leave me in this big, amazing, gigantic institution. And I sort of wanted them to stay too. But I had the time of my life here. And I majored in American Studies and Human Biology, which I think speaks to the depth and breadth that arts and science has to offer here in Toronto. And then I left to go to medical school at Queen's, I'm sorry. And then I came back to do my residency in psychiatry at the Temerity Faculty of Medicine, as well as a master's degree at the Institute for Medical Science. And I ended up working at CAMH. I'm the medical head of our emergency service there. And I worked right beside New College, right on campus at College in Spadina until we moved about a year ago. And my husband is a graduate of the Faculty of Applied Science and Engineering. So being here today feels very much like coming home. Before we start, I do want to say that I know that this is a heavy topic, and if you have struggled with suicidal thoughts, please know that you matter and your life matters. And if you've lost a loved one to suicide, please know that we see you and we hear you, and we're so sorry for your loss. So, as I was preparing for this talk, there's so many people here with so many incredible backgrounds. I asked somebody from Temerity, from the Temerity Faculty of Medicine, who is a much better speaker than I am, Dr. David Goldblum. He's written a couple of books and everybody knows who he is. And I said, David, how do you talk to a bunch of people who all come from different fields? And he said, Juveria, tell a story, because the only way to connect with people is to tell a story. And so for me, I wanted to start at the beginning of my story. So in this picture here, this is Masjid al-Nur. So it's the first mosque in St. John's, Newfoundland, where I grew up. When my grandparents emigrated to Newfoundland, they were like 10 Muslim families in the entire province, and they would pray in people's basements on Friday, and they would have their Eid celebrations in someone's living room. And I think it was my grandfather's greatest accomplishment, besides, I hope, his family, that he was able to help raise money for this mosque. And this mosque was like the only game in town, so it was great because if you were a Shia Muslim or a Sunni Muslim or from Egypt or Indonesia or India, you had to go here. And so you met all kinds of different people, and it was an incredible place to be. I don't know which kid I am, just looking at the picture. We all, from this distance, we all kind of look the same. But I think I am in there. One of the things about immigrant communities, and I think many communities, is the focus on achievement and giving back to a country that has given so much to us, helping people in some way. And the pinnacle of that dream for my family was medicine. And I remember when I got into medical school, there was so much excitement and conversation. And I remember them saying, well, you can do whatever you want, but don't do psychiatry. And I said, why not? Why can't I do psychiatry? And they said, because that's for crazy people. Our people don't have those problems. And I thought about that. Our people don't have those problems. What did that mean in our community? And it didn't make sense. I knew it wasn't true because both of my parents suffered from quite severe mental illness. So I knew that we were suffering in silence, and I wondered about the kids in that picture. How many of them were suffering in silence too, and their families as well? And how many communities across this country have people who are suffering in silence? And if we can't even talk about mental health, how would we ever talk about suicide and suicide prevention? And so that stuck with me, and I think has guided my career. How do you tell a story when you're not even allowed to tell the story? And as far as stories go, suicide is one of the most tragic ends to somebody's story. It not only deeply affects the person whose life is cut short, but it affects their families, their friends, their communities. Of all of the people in this hall and all of the people watching online, if I asked you, I'm sure almost all of you have been touched by suicide in some way, whether it's struggling with suicidal thoughts, losing a loved one, or trying to get support for somebody that you care about. Suicide affects all of our lives, but it still lives in the shadows. You know, we're so ashamed to talk about it, we're scared. And I think these complicated discourses make it difficult to tell a story, and the messages that we get even in mental health care and mental health research are mixed. So we hear, well, talking about suicide is dangerous, we shouldn't mention it. Well, we can't prevent suicide, it's something that's a personal choice. Well, everybody who dies by suicide has mental illness, so maybe just treat the mental illness. We're going to find the suicide gene. There's no such thing as a suicide gene, it's about much more than that. It's just thoughts, it doesn't matter. They're not gonna do anything. You hear that a lot often with young people too. So how do you reconcile this? Like, how do you tell a story when the story is so muddled? How do you tell a story that makes it easier to hold on to hope? And when we have these muddled stories, it makes it difficult actually to create innovation and change. So we know that research is a place where we can create innovation and we can make change. But suicide prevention research, despite the fact that I see people nodding in here, people are affected by suicide, and in studies of the general population, they care about suicide prevention. But suicide has been woefully underfunded. So for example, in the National Institutes of Health in the United States, about $100 million a year goes towards suicide funding, suicide prevention funding. $700 million a year goes towards breast cancer, which kills fewer people every year. And that's not to say that breast cancer isn't important, it's extraordinarily important, and the money that's raised and the research that's done has reduced mortality considerably. But what about suicide? What about suicide prevention? And what about those families that are affected? So how do we change the way we tell the story? So I'm an emergency department psychiatrist. I work at the Center for Addiction and Mental Health, which is part of the University of Toronto. And I'm the medical head of that service. And we're the only standalone psychiatric emergency department in Ontario. And every day I see people often on the very worst days of their lives. And they were so scared to come in. And we say the same thing. I say the same thing to most people I meet, whether they come in because they want to or they don't, or they think they need to be there or they don't, or they have schizophrenia or anxiety or depression. I'm so glad you came in today. I'm so glad that you're here. You're not a burden, you matter, and it's important that you get the help and hope that you deserve. And so instead of thinking about suicide as terrifying or unsolvable or murky or shameful, we need to think about suicide maybe then as the consequence of tremendous emotional suffering. It's a tragedy that affects families, communities, society. And I think it's also really important to remember that having suicidal thoughts in and of itself is incredibly painful and requires urgent treatment and support. We can't always focus on preventing death. We need to create life. We need to create a world, again, where every life is worth living. The theme for World Suicide Prevention Day last year was working together to prevent suicide, because preventing suicide requires the efforts of all of us: family, friends, co-workers, community members, educators, religious leaders, healthcare professionals, offices, workspaces, political officials, government. It requires also the voices of the people who are affected by suicide, suicide attempt survivors, and those of us who've lost a loved one to suicide or are supporting a loved one with suicidal thoughts. One of the most exciting things I think that's happening at Temerity and across the world in medical research is patient and family engagement. We know that in general, patient and family engagement improves outcomes. It creates research that actually makes more sense and has like outputs that actually help people. It makes people understand the work better. It helps us use language that actually is accessible and useful for patients. And it makes sure that what we're designing is actually what people want and they want to use. But for whatever reason, we don't see that as much in psychiatry, which is interesting because it's a talking field. And in suicide prevention in particular, how can you ever help someone who's suffering if you don't ask them about their suffering? How can you figure out what a person needs when they're unwell when you don't ask them what they need when they're unwell? So one of the things that we're really proud of is engaging dual expertise researchers. So moving even beyond lived experience or patient engagement to create a world where people who have lived experience of suicidal thoughts or family members of suicidal people can come get professional training and get skills and get access to resources and a living wage to really create work that matters. It recognizes and values the full breadth of a person. So it's an approach that we take that we're really, really proud of. So if you want to change that story, you had to break it down. So it's a big story, it's a scary story. So how do we make it smaller? How do we make it less dark? How do we make it less heavy? How do we shine a light in the darkness and help reduce that shame and stigma? So we'll focus on the what, the why, the how. I have a 9-year-old and a 4-year-old, so if you break things down into smaller pieces, it always feels a lot easier, and I know that's the case definitely for me, sitting in front of a computer trying to figure out what to do next. So the what is using population level data to understand suicide risk. So people are really unique, and their communities are unique, and who they are unique. The risk for suicide for someone with schizophrenia is going to look different than the risk for suicide with someone with depression. The experiences of someone who's 17 are going to be different than the experiences of someone who's 71. And when we do a one-size-fits-all approach, we actually don't know what's happening on the ground. For example, during COVID, if suicide rates go down for middle-aged people, it might wash out a difference that we see in people over 80 or people under 18. So we have to actually look at people as individuals and communities. And so some of the work that we do is using population level data to understand suicide risk. So this is an example of a couple of studies that we've done using ICS data, which is also part of the U of T network. So for people with schizophrenia, their suicide risk looks a lot different than people who don't have schizophrenia, which seems really intuitive, but when you actually assess for suicide risk, you don't really differentiate between the two. So people with schizophrenia only account for 1% of the population, but they account for about 23% of all suicide deaths between the ages of 25 and 34. So suicide risk tends to come sort of in middle age and later age, but for these folks, for young people, if someone has a psychotic disorder, we really need to act and we really need to help and we really need to support them. In some other work that we've done, we found that people with schizophrenia who were diagnosed later tend to have a higher risk for suicide, which is actually really surprising because you think, well, if they get sick earlier, that's more time to be sick. But if you get sick earlier, you may have more family support. You may have more support from your school. You may have access to first episode psychosis programs, which are an incredible way to reduce mortality on a population level. But if you're diagnosed when you're 29 and you can't get into the program when you're 30, that's a big problem. So all of this to say that by understanding what the data looks like, we can actually develop targeted interventions that are specific to meet the needs of people who really need the support. And then it comes to the question of why. What is really important? Who is at risk? What are the risk factors? But if we don't understand why, I'm not sure we'll know how to help and support. And so I'll give you one example here. Women in China up until about 10 years ago had higher rates of suicide than men did, which is very unusual. So for example, here in Canada, men die by suicide more than 3 times, at a 3 times higher rate than women do. And women who emigrate from China and even going 2 or 3 generations forward have higher rates of suicidal thinking and suicide-related behavior in a North American context. And so if we kind of do a washout effect, if we say, well, women die by suicide less than men do, we're gonna miss this really important data. So now we have the data. Okay, we know that Chinese Canadian women and Chinese women are at higher risk for suicide. So we can make a lot of assumptions, right? And that's really dangerous. We can say, well, it's because of model minority pressures and it's because of stress at school. But we didn't ask anybody. We can say it's because of trauma and oppression and immigration stress, but we didn't ask. We can say it's because of higher rates of depression or lower rates of depression, but we didn't ask. And so in this study, what we did is we interviewed women, many, many women from Beijing in China, as well as rural areas in China, and across the GTA in Toronto, and we found some really interesting ideas that kind of tied everything together. So it wasn't just stress and pressure. So these women did describe feeling under incredible stress and pressure in their families, with immigration stress, with other types of trauma, financial stress. But what they talked about is how that stress and pressure actually made their depressive symptoms worse. So it made it very difficult to eat. It made it difficult to sleep. It made it difficult to enjoy life. But what they talked about is that, culturally, people talked about this idea of REN, or endurance. It's my job to meet my obligations as a mother, as a wife, as a worker. It's my job to keep pushing through. And I think many people, women and all people, can identify with that. I need to meet my responsibilities. I need to keep pushing through. I know that's something that comes up in my culture very often. And so as they push through, they don't get help or support, their depressive symptoms worsen and worsen. And it manifests itself in physical symptoms. So, whereas one person may say, I can't get out of bed because I just can't face going to work and I can't concentrate when I'm there. Another person may say, I feel the pain in my body, I feel it in my stomach, I feel it tingling in my hands. And it's a difference, right? And it depends on how you grow up and how you express yourself and what your culture kind of dictates, right? And then one of the things that was really interesting is these women often seek treatment for insomnia. So the stress and pressure builds up, it hits a breaking point. They go to their family doctor and say, I can't sleep. And so, if we don't have this data, what can end up happening is we prescribe sleeping pills, which can end up becoming lethal and overdose. But if we know this and someone comes in and says, I can't sleep, then as a physician, I can say, tell me what's going on in your life. How's your concentration? How's your energy? How's your mood? And we can actually treat the underlying issue. Oh, I understand you're having financial stress. Can we talk about that? Can we get you connected to social work? There's so much more we can do if we can understand the different patterns. Another really important thing that we need to remember is that suicide is preventable, and there is hope and there is help. And the vast majority of people who die by suicide, the vast majority of people with suicidal thoughts don't die by suicide. It's really, really important to point that out. But I think it's also really important to remember that the mental health system is fractured and it's difficult to access and it's heartbreaking. And I have people, friends and family and acquaintances call me and say, hey, Juveria, how do I get someone into care? Or can I bring someone to CAMH? Or, what's out there? And it's very different if you're in Toronto or if you're in Timmins as well. And so we need to understand how people feel within our mental health care system and how we can actually improve care. So we do lots of studies looking at this. We look at patient, family, and provider perspectives on how to improve care, and we build interventions from that. But one of the things I wanted to talk to you today about is a study that we did a couple of years ago where we looked at suicide notes here in Toronto. So we had a sample of about 300 suicide notes. And I'll remember it. I was quite junior in my career, and I would take the subway from North York, where I live, to the coroner's office, and I would have to clear the security and go up there and sit by myself and transcribe the suicide notes into my laptop in a protected file. And I was pregnant. I was pregnant with my first daughter, and I have those same brothers and sisters that I'm still very close to. And then you read notes, and they remind you of people you love, like your siblings and your unborn children and your husband and your parents. And again, in the emergency department, I get to see people on a hard day, but on a day with hope. And so it was really heartbreaking to engage in the material this way. But you feel like you have a responsibility, right? Like if we have access to this data, how can we honor these folks by making a difference and trying to figure out how we can improve care? So one of the things that came out in our work is I think people, and I among them, you think of people who have suicidal thoughts, they just must be really sad, or they must be really down, or they must be really hopeless. But one of the things that came out very clearly in the notes is people are exhausted. They are so tired. Because you think, okay, well, it's biological, I'm gonna go get X treatment or Y treatment, but if those treatments don't work, and I know as a psychiatrist, a third of people respond to the first treatment, a third of people respond to the second, and a third of people need a little bit more time to figure it out, but almost everybody gets better. You don't know that when you're in it. And so when you're in it and you're trying new things and nothing is working, you get so tired, and that exhaustion, what really came through in the notes. Another thing that came through in the notes is there must be something wrong with me. If it's biological and I'm getting treatment and I'm not getting better, then maybe there's something wrong with me. And the third thing that came out was themes of powerlessness. Everybody's telling me to hold on and to fight and to get better, but I am tired and I need to do something to break this cycle. But this is all really valuable information because we can use that when we work with people. So if I meet someone in the emergency department now, and we use this paper with residents and we use it to improve care in our program, we can say, you must be really exhausted. Can you tell me about that? And you can see people open up in that moment. Or, it must feel really powerless that I'm telling you that you have to stay here, but you're telling me that you don't think it's going to help. Can we talk about that? And so understanding these narratives can help us have these new entry points and these new pathways to care that we may not have thought of otherwise. Another piece around suicide prevention that I think is really important is the how. The what and the why are really great, but what are you going to do with it? And so the how is like taking all of this information, the what and the why, and putting it into play, into work to actually help people, which is like really what we should be doing. So this is one thing that we're really, really proud of. It's the Canadian Armed Forces Clinician Handbook on Suicide Prevention. So we were able to take all of the best practices, all of the research in suicide prevention, in military suicide prevention, and create kind of a standardized backbone. So it's like a common playbook, so everybody's on the same team. So if you are a member of the Canadian Armed Forces, your family doctor and your psychiatrist and your psychologist and your social worker are all going to assess risk the same way, and they're all going to know how to communicate with each other so nothing gets missed, and they're all going to know what to do when something comes up. So what are the evidence-based practices that are right there in front of you? So things like means restriction, getting rid of dangerous things in the house, things like engaging family, things like starting treatment. And so we're really, really, really proud of this. And I think this quote from the former Minister of Defense really resonated with me. Like, suicide is not just one thing, it's deeply complex, it's multidimensional, with no single cause or simple solution. And when something is complicated, we need a playbook, like we need to work together and have a very eclectic and organized approach. And this is really wordy, so you don't have to read the slide, but this is another study that we're doing looking at the how. So I think for a long time, excuse me, I'm sorry, it's bronchitis, I promise. For a long time, people were afraid to do research with folks who have suicidal thoughts. So if you're trying to test an antidepressant, one of the rule-out criteria is having suicidal thoughts. So all of these medications are developed without suicidal people in mind. And I know that if you have a loved one who has cancer and you're going to Cancer Centre of Ontario intake appointment, they're going to tell you about research and studies that are ongoing. This is a positive. And when research is happening in clinical institutions, care often is better because the care follows the research. And so one of the things that we're really passionate about is integrating research into clinical care in the CAMH Emergency Department, and being inclusive around the research. So not saying you can only be in my study if you're over 80, or you can only be in my study if you don't use alcohol, or you can only be in my study if you have housing. We are going to include everybody, because how are we going to understand trajectories if we don't include everybody? So this study is going to take a cohort of 500 people who register in our department who have suicidal thoughts or suicidal behavior, and we're going to follow them over a year. And we're not going to just look at their blood, which we will. We'll look at genetics, we'll look at biomarkers, we'll also look at their stories. We'll talk to them and do in-depth interviewing at 1 and 4 and 12 months. We'll also look at their service utilization, so we can link their health card to see, do you come back to hospital, do you not come back to hospital, do you go to your family doctor for care, where are you getting care? And we'll also try to understand whether they have higher rates of impulsivity, whether they have higher rates of mood symptoms, whether they use substances. We want to understand them as full and whole people. So really excited for this work, hoping to recruit our first patient in March of 2023. And I think that brings us back to our first slide. All those kids standing there in front of the mosque, and thinking about the what, why, and how of preventing Muslim youth suicide. So one of the challenges is in understanding Muslim youth suicide is a lot of Muslim countries don't release data because it's forbidden in Islam, and so we don't actually have the data. So, and if something is illegal, you're not going to report on it. So we have no idea. And then in countries like Canada, your religion isn't listed on your health card, for example. So that makes things really tricky as well. And historically, I think in medicine, we've had a very difficult time recruiting appropriately from underrepresented communities, because I think we want to do things all one way, and then you end up with a sample of people who all kind of look the same and think the same. So in this study, it's the first of its kind anywhere in the world. We're going to look at the what and the why and the how. So we're going to look at linked health administrative data across all of Ontario to pick out young Muslims by looking at people who are born in a Muslim majority country or who have a mother who was born in a Muslim majority country. So that's the way we get sort of 2 generations of folks. And we'll look at rates and risk factors for suicide across country of origin and across gender and across immigration status. And then we'll also interview, and we have been interviewing young Muslims across the GTA, across the Muslim diaspora, to say like, hey, what's been going on in your life? Like, what is the role of gender and culture? What is the role of Islamophobia? What is the role of meaning familial expectations? What is the role of stigma? And rather than making assumptions about what's driving their distress, we can actually ask them. And then we'll have focus groups of young Muslims. There's a lot of people with lived experience on our team. And we're also engaging with religious leaders, the chaplains at UT Scarborough and UT Mississauga and UT St. George, who will actually work with us to do analysis of Islamic holy texts like the Quran and the Hadith. And then we can say what they say about suicide, and we can compare it to what the kids are talking about in their families. And that way we can kind of build this infrastructure that we can go to religious organizations and religious leaders to say, here's how we could talk about suicide in a way that is culturally congruent, and it's a way that is in keeping with your values too, and that way we can help more people. One of the things in Islam is that, and it's not dissimilar from Catholicism or other religions, where suicide is a mortal sin. It's not just a sin, it's a mortal sin. But there's also a passage in the Quran that talks about when Mary, or Maryam in the Quran, or Mary, was laboring with Jesus, or Isa in the Quran, and she's in so much pain she wishes for death. But it doesn't mean that she's a bad person. It doesn't mean that she's not deserving of hope and care. It means she's in pain. And so we often use that passage, for example, and that's come up in our work as a way to kind of connect with different communities. So, when we were preparing for this talk, I didn't know if I wanted to talk about COVID. I think everybody is COVIDed out. Everybody's tired of COVID. We're in the 6th wave of COVID. But I will say, as a suicide prevention researcher, more people have talked to me about suicide prevention during the, one second, and I just picked up my phone. There we go. It's fine. More people have talked to me about this in the last 2 years than ever before. And I think we know that COVID-19 is having a negative impact on people's mental health. Like, I don't think that's a surprise to anybody here. We know that over 50% of Canadians feel like their mental health is worse. 24% of Canadians are saying they're using more alcohol. Suicidal thinking usually is around 2.5% in a community sample in a recurrent survey. During the pandemic, it ranges between 6 and 12%, which is like considerably higher, right? Imagine 12 out of every 100 Canadians is having suicidal thoughts in a given month during the pandemic, compared to 2.5. So this is a really big deal. So I did want to sort of approach it and discuss it and kind of and talk about how we can be hopeful about this moving forward. So I don't know if you remember, and I didn't want to include anything in the presentation because they can actually be quite triggering, like early media reports. So in March 2020, and I remember I was asked to do quite a lot of media at the time, it was this idea that suicide rates were bound to increase. There was no doubt about it. They were going to increase because of lockdowns and financial stress, and they were going to increase because people would have brain changes with COVID, or they were going to increase because someone would give someone COVID and they would feel so guilty and they would die. And we would hear these stories in the media quite a lot. And it's very problematic because it makes suicide, which is very complex and multifactorial, seem to be about one thing. And when you make something complicated about one thing, it creates this narrative that like it's inevitable, or we can't fix it, or we can't change it. And so media, like reporting on suicide inappropriately in the media, can actually show an increased risk for suicide in a population. So you might end up with increased suicide rates just because you're reporting inappropriately. And the other thing to remember is during both world wars, suicide rates actually went down because if you're very depressed or anxious, you feel very alone. But early in the pandemic, there was this sense of collective purpose of we're all in this together. I don't think that's the case necessarily anymore, certainly, but I think it was at the time. So there was a question about what would happen with suicide rates. And it was an event that was completely unprecedented in our lifetime, so how could we ever speculate about what would happen? This is a very busy slide, so my apologies for this. But the reason I put it up is because it's nuanced, and it tells like a more interesting story. This paper was published in April of 2020. It's not my paper, so I'm completely unbiased. And it shows the risk factors for suicide and how they may be affected by the pandemic. So we shouldn't be alarmist, but we do need to be vigilant, was the message. So for people with mental illness, which is the first column there, it's really important to distinguish between the anxiety and depressive symptoms that all of us feel in this awful time that are completely appropriate and justified, with those that cross over into impairment, with the ones that make you not want to get out of bed, that not want to live anymore, not want to eat. It's a very important distinction. And certain groups we know were potentially at higher risk of developing mental health issues during the pandemic, and we'll discuss that as well. But we also know that certain people, and we've done some studies, we interviewed about 70 people about their experiences of suicidality during COVID. And they said, some people said, I felt much worse. Other people said, I felt much better because I was with my family more. I didn't have to go to my terrible workplace. You know, I could work from home. Some people said I couldn't see my psychiatrist anymore and it was terrible. Other people said I could finally get care virtually and I didn't have to decide between going to my job and getting care. So it was a mixed bag. So I think it's really important to kind of remember that. Regardless, though, we do know that COVID-19 has a disproportionate effect on those with mental illness. They have lower rates of vaccination because of institutional trauma or difficulty accessing care. They have higher rates of death, higher rates of complications. So this is a major issue right here. But for people who have suicidal thoughts, we actually have no idea how the pandemic affected them. Before the pandemic, we know that if you take two people, one has depression with suicidal thoughts, the other doesn't. The group of people with depression with suicidal thoughts actually gets much worse care. They have more diagnoses, they access care less, they have higher rates of mortality, they have higher rates of marginalization. So you would think, like, intuitively, if someone had a worse illness, they would get better care, but that's never been the case for people at risk for suicide. And so you can imagine how those discrepancies can be reproduced in something like a pandemic. And then you see the next three columns, domestic violence. So if you're in an abusive situation at home, you know, you can't get out of home, and it's heartbreaking and it's scary. And people are under a ton of stress, and so we saw higher rates of domestic violence, higher rates of alcohol consumption, as we discussed, certainly financial stressors. So these are all things that could potentially worsen during the pandemic. And then I think the last, we talked about media reporting, the second to last column is access to means. I think all of us have very heavy hearts right now. For me, as a parent, it's very difficult to engage with the news right now. But we do know that during the pandemic, gun sales in the United States skyrocketed, like very significantly. That could not be explained by another factor. And having a gun in the home is an independent risk factor for suicide that's very significant. So that means there's much higher rates of suicide in that home, even for people who don't use the gun. So for somebody's wife or somebody's child, the rates of suicide are much higher because you have this object in the home. So that's another thing to consider. So what did we see in our own local setting? I think if you have the misfortune of knowing someone in healthcare, they like talk to you about COVID and their terrible experience with COVID over and over. So I'm gonna do that now. So my sincere apologies. But for us at CAMH, the world changed on March 11th. I've never seen anything like it. When I started as a resident in 2007, we'd see like 350 people a month. And the year before the pandemic, we were seeing 1,200 or 1,300 people a month. So our rates were skyrocketing, which is great because anti-stigma, getting care, but difficulty access were a great place to go. So we were really busy. Then do you remember March 11th when everything shut down all at once? The rest of the month, instead of 1,300 cases, we were seeing 700. But we know that people are still suffering, and I think you see this in the data around regular emerges. Like, people are still having heart attacks, people are still having strokes, but nobody is showing up. And that's really concerning. And I think part of that is a fear of getting COVID. Part of that is wanting to follow the rules. Part of that is maybe a little bit of a protective effect because you maybe remove yourself from some stressors. But I can tell you what we did see. We saw a lot of young people. So people whose school life was disrupted, a lot of students, people whose future plans were disrupted. We saw a lot of older folks who very reasonably were concerned about getting COVID, and the kind of having to be isolated from friends and family was really challenging and difficult for them. But the population I think we were the most worried about was the most vulnerable of Canadians, you know, people who were incarcerated, for example, people who are homeless, people under financial stress, people with disabilities. And we saw so many people with marginalization who were coming into our department. It was heartbreaking. You would see people who were stable with their schizophrenia for 15 or 20 years who now are struggling again because they can't go to their community drop-in. They can't see their caseworker at Tim Hortons. And so these kind of fractures and fissures in the social network, I think were really hard for people. And we would also see a lot of substance use kind of later on in the course. I'm sure, I'm not gonna make you raise your hand, but I think a lot of people were drinking more during the pandemic because of lots of reasons, right? Like boredom, you're not going out, easy access. And so we would often see people in withdrawal from alcohol or people with severe opioid use disorder, like kind of much later in the course of illness, because it would kind of start, but then you couldn't get help. And so people would have more severe complications by the time they came to us. I think last August was the highest number of opioid overdoses ever in the city of Toronto. And that there's a mix of factors that lead to that, but it's completely heartbreaking. And so usually our volumes follow the waves. So when the wave comes, our volumes come down. But one of the things that's been really interesting with the wave, I guess it's 5 and 6, but starting in December with Omicron, there's been a decoupling, meaning that rather than following the same wave, our volumes are going up while the cases are going up too, which is very unusual for us. And it's very difficult for healthcare providers because a lot of our staff gets COVID. So there's like no one to care for anybody, but people are coming through the doors. And so, we want people to come though. If they're not coming, that means they're not getting help. So I think that kind of keeps us going. And the data showed, we talked about this initial concern about an increased rate for suicide, but suicide rates were actually found to be very stable across several countries. There's a huge living systematic meta-analysis that's ongoing that you can access. That's great. That shows you that the rates actually stayed really stable. But then remember we talked about that what question, right? Does this apply to everybody or does it apply to some people? And if you actually parse the data a bit more carefully, you see that you have increased rates in specific groups. So Black men, racial minority groups in the US, women in Japan, as well as young people everywhere. So young people under 24 everywhere across the world, higher rates of suicidal ideation and behavior. We don't know if that's translated to suicide death, but the signal is definitely there. And you notice these other things like increased distress in survey data, increased calls to the Canadian Suicide Prevention Service. So how can qualitative research help? So this is my plug for qualitative work. If suicide is underpinned by biological, psychological, social and cultural factors, economic, social and health system disruption during COVID, we need to actually talk to people about what's going on, because if we don't, we can make all kinds of really dangerous assumptions, and we may build this beautiful virtual clinic that nobody wants to go to because that doesn't actually help them. So and we have to understand what works in Kamloops might not work in Kelowna, right? We need to really understand the geography, the differences in age, the differences in gender, and across diagnosis. So qualitative research seeks to understand the experiences of individuals with suicidality. So we can just kind of challenge top-down research practices. We can challenge me saying to you, I'm the doctor, I know what's gonna help you, and we actually have no idea. And we can kind of co-design interventions that work. And this happens across other fields in medicine and internal medicine and pediatrics. You do a first phase of qualitative work to inform what you design, and then you can test it. And so we recently received funding from CAHR to look at suicide in the COVID-19 pandemic. And you can see all the people who are working together to do this across 4 provinces. We're going to interview about 120 people across every single sociodemographic and clinical characteristic you can imagine to say, what's your story? If you had suicidal thoughts before the pandemic, how did they evolve during? If you had them during the pandemic, how did they evolve? What helped, what didn't? What are your protective factors? What are your risk factors? In a perfect world, what could we have done to help you and help your suffering? So that's the next step for us. So I want to end by going back to that question, what is the story we're telling? And these are my daughters. The one on the left is Hannah. The one on the right is Zara, although they're flipped. Big is Hannah, little is Zara. I don't know if any of you watch Survivor, the show, but my brother was on Survivor, and he shouted out my daughter, and then the host of Survivor was like, Hannah, and now she's famous. So now she's double famous because she's here. But people often say to me, Juveria, your work is pretty dark. What do you tell your kids? Do you tell them that you do suicide stuff? Do you just say it's about feeling sad? How do you talk to a almost 9-year-old and a 4-year-old about suicide? And I think my answer is a bit different. I want to tell my girls that, your feelings are normal. That if you feel sad or mad or worried, we're always here to talk to you, and those feelings are normal, and you're allowed to have those feelings. For some people, and maybe even for you someday, You might feel so sad that you don't want to eat your dinner, or you're not going to enjoy seeing your friends, or you might not want to get out of bed. And for some people, you might get so worried that you can never stop worrying and your head goes faster and faster and faster. Or you may feel so confused you don't even know what's going on. And if that ever happens to you, we're here. And if you ever feel so sad, some people may feel so sad that they're not even sure they want to be alive anymore. That's called having a suicidal thought. If you ever feel that way, we are here. And there's hope and there's help, and we're going to get through this together. And I think about my family and the idea that like our people don't have those problems, and mental and psychiatry is for crazy people. You know, I think like over the years they've come around quite a lot. And my grandpa like talks to me about how he feels anxious now, and it's amazing to see like these generational changes that can happen. And so what I hope is the story that we're telling is a story of hope. Like, things do get better, and we have treatments that work. We need to make sure that people know they're loved and that they matter, and we need to work together as a society to create a world where every life feels worth living. If you ever have suicidal thoughts, or if you're ever looking for help, no matter where you are, the CAMH.ca website has extraordinary resources, crisis lines, information, access to services across the country. So please do check that out. Thanks so much.
Hello, thank you for this wonderful presentation. I'm wondering if you've actually looked at the rates for Indigenous people across Canada.
I think this is one of the most important questions that we need to wrestle with as a nation. And you know, as a person who's not Indigenous, I think it's really important that we have people from Indigenous communities doing the work and leading the work and having the funding to do the work. So at CAMH, we have extraordinary Indigenous researchers. We have a new Indigenous research hub as well. And we hope that we can do real community engagement and real work to build protective factors, and also to sort of address the structural determinants of suicide risk, so clean water, food insecurity, inherited trauma, you know, violent experiences with policing. This is all part and parcel of suicide prevention. Like, suicide prevention is housing. Suicide prevention is freedom from trauma. We also know that in the literature that the more well-supported a community is and the higher the connections are within the community and the lower burden of trauma and socioeconomic stress there is, the lower rates of suicide there are. So I think it's really important that we understand that link and we invest in these communities without just saying it's a matter of prescribing a medication or getting a psychiatrist up there. These problems are serious and they're deep, and I think as a nation this is something that we need to invest in maybe more than anything else.
I'm really pleased to have this opportunity to be here. I'm over here. I would like to ask you, though, even though you do mention CAMH and they're there to help, it's no secret that it's very difficult to get help anywhere. I mean, lists and lineups and people are just not getting it. Now, can you tell me, I even have a family member that needs help and we're not able to get it. So I just wonder if you could reiterate what you would do in a situation like that.
Absolutely. So I'm going to start with the big picture, and then I'm going to move to the small picture, because the small picture is actually much more important because it's what you're experiencing and what people's families are experiencing. From a big picture perspective, there needs to be accountability within the mental health care system. So if you look at Cancer Care Ontario, for example, no matter where you live in Ontario, if you have cancer, you are referred to the proper level of care for your diagnosis and to the closest site that can provide it. There's a centralized wait list and a centralized access point, and there's treatment to target. You're not just going to randomly get one treatment or another. It's going to be an evidence-based treatment, and if that doesn't work, you're going to move to the next step. Paul Kurdiak, who is my mentor and a University of Toronto newly minted professor, actually full professor, is the head of the Centre of Excellence in Ontario, and they're working to do exactly what you're saying, so to reduce the wait list, to improve access. So that's the big picture question. The little picture question is, what do I do, though, for my loved one who is suffering right now? So the first place to go, and I'm sure you've done this, is to your family physician. A lot of mental health concerns can actually be managed quite well in a family physician's office. So depression, anxiety, remember we talk about a third of people respond to the first treatment, a third respond to the second. So that's a good place to get started. There's also the CMHA in your local community, the Canadian Mental Health Association, who can help you navigate what's available and what isn't. I think it's very, very difficult because it feels like you have to be a genius to like go on the websites and look and try to find someone to help support you. I think, you know, family doctors who have embedded social work and nursing tend to work the best, like a family health team, because that way you can get started with care, and if you need more or extra, it can go to the next level. If you or a loved one is not getting help and is not getting support, go to your nearest emergency department. I know it's very scary, it's very frightening, but sometimes that can be another way to access care quickly, whether it's through urgent care or whatever is provided in that place. There's also one of the things that's really interesting with COVID is this pivot to virtual care. So there has been a real investment in online provision of things like cognitive behavioral therapy, and the evidence for these interventions that are online is actually quite good. It's very good. And so if your symptoms are mild to moderate, you know, and I won't name anything. I have no shares in anything, I promise, but going online and finding a kind of online service provision may be like a good kind of first step when you're trying to figure out what to do in person. If your loved one goes to a university, going to your university health and wellness is really, really useful. U of T has really great mental health resources and services, and that's another place to start as well. Thank you. I have 2 questions. I'm going to start with the first one. In your research and experience, how has social media led to higher suicide rates for youth, especially girls? So, you know, my perspective on this is maybe a little bit different, and I think it comes from listening. I have a lot of very close colleagues and collaborators who are child and adolescent psychiatrists, and listening to them a lot. And I think I feel that way as a parent, like we're sort of in a rush to blame like a particular cultural phenomenon for an increased rate in suicide, but I don't actually think it's that simple. I think about, you know, LGBTQ2S people in small towns who can use social media actually to connect with people that they care about. Especially during the pandemic, social media can be a lifeline for folks. So I think anything that becomes obsessive is dangerous. I think anytime, and people talk about the highlight reel effect where on your Instagram you're only showing the greatest moments, but I think that happens in life in different ways too. I don't think there's anything necessarily particularly unique about social media. One thing about social media that does have evidence that we do need to worry about is contagion effects. And so if people are, so I don't know if anyone remembers the show 13 Reasons Why, but there's a associate professor at the University of Toronto, Mark Senior, who is a friend and colleague of mine, who is part of an international network that studies like social media messaging and these shows. And when you have these so in the show, this young woman sort of dies by suicide, and it's sort of portrayed as this kind of beautiful romantic ending. They show a method. It's showing as a way to get back at people who punished her. Those kinds of messages actually led to an increased rate of suicidal behavior in young people. So I think the one thing I will say is for social media is to be very careful with your messaging for all of us. And then the next question is, why do patients need to provide consent to receive mental health services? Why a family member or someone who cares about them can't seek service on behalf of a loved one? Oh my goodness, you know, this question breaks my heart, and we do a lot of research with family members, and I talk to family members every day in my job, and this is something that comes up over and over. And I think I have 2 answers for it. The first is the history of psychiatry is something that we need to grapple with. The history of psychiatry is racist, it's oppressive. It's, you know, a family member says, I want to lock this person up for 3 months, and they get locked up for 3 months. And I know this from some of the international work that we do. In some countries in this world, you can just commit your loved one. And at CAMH, we really wrestle with our own institutional kind of oppression too, where we had people admitted for 20 or 30 years and over-medicated in the 40s and 50s. And so I think sometimes there's a pendulum effect. So we go from having the families have all the control and the institutions have all the control, and then we move to more of an individualistic model. But I think the difficulty with that is sometimes that can be an excuse not to engage with families. And I think we need to, as providers, there needs to be an ethos that it's always family first. So for example, at the University of Toronto, there's discussion about having when you come and you sign up, is there a way that we can say, we have your consent implicitly to talk to your family. You can revoke it, but we're starting from a place of yes versus a place of no. And I think that's really interesting and innovative. As an emergency psychiatrist, I always say, I can get information from anybody. I can't necessarily give information out. And so I think there needs to be a bit of a shift to find a third way. Confidentiality is really important, but so is someone's life. And then the last thing I'll say is that depending on the illness, the evidence for coercive treatment, so treatment against one's will, may not actually be that helpful. So for schizophrenia, for example, if I had schizophrenia and when I'm not well, I don't think I have schizophrenia, and I may do things that may not be in keeping with my values or who I am in the context of my illness, but I don't understand or appreciate I have an illness. My loved one, my husband, could be my substitute decision maker and make decisions for me, and if I don't follow the rules, I may have to come into hospital. But there's actually good evidence for that. Although there's questions about whether it's ethical or not, there's good evidence that can actually help people. For things like opioid use disorder, for example, there's not very good evidence for it. So if a family member says you have to keep my child in the hospital because they're using opioids, and I keep them in the hospital and they don't want to start Suboxone or methadone, I can't force them to take a pill. If they leave in the community, no one can force them to take a pill at home. And then by keeping them in the hospital, I actually reduce their trust in the mental health system for when they're ready to get care, and I can increase their risk of death because they can have worse, they can lose tolerance in hospital and then go out and use. So I think it's a complicated issue, but I think the most important thing is if your family member there are organizations that can help you advocate. So there are different organizations that are, like the Schizophrenia Society of Ontario, for example, Al-Anon, who can kind of help you it's almost like you need to become an expert to navigate the system. And I think we need to do better in terms of supporting families to be that expert and be a bit more flexible when we can be. Just wanted to hear your thoughts on medically assisted suicide. Doesn't this conflict with your belief of every life worth living? So I think we need to create a world where every life feels worth living, but not force people to think that their life is worth living. I am a really strong believer in made for medical issues, for end-of-life care. That's just my personal belief. Knowing people who have had a family member with, like COPD, for example, having to be able to have a good death, I think that's really important. I think one of the challenges when suicide prevention and MAID, and this is not my area of expertise, and I don't want to speak out of turn, is that if we say that MAID should not be allowed for mental illness, it closes a door for folks. So my view is that if someone has suicidal thoughts, that's an emergency, and we need to treat everything that we can. We need to walk down a path with someone and say, what are your risk factors? How can we modify all of them? Have we tried ECT? Have we made sure you have safe housing? Have we gotten you some family counseling and family therapy? We need to do everything in our power to make sure that they can feel as though their life is not worth living. It is not it's not my job, or it's not appropriate for me to impose my values on other people. But I do think that we do need to help ease suffering, and I do know that often when people do have mental illness, and it's not often, almost always, and they're treated, those suicidal thoughts do abate. It's just in the same way you wouldn't do MAID for someone who's in extraordinary pain for a broken leg when you can fix the leg. It's a bit glib, but kind of same idea.
Question here. You talked about a lot of really great research about those having suicidal thoughts, and I think that's really helpful in normalizing and naming some of the situations people are going through. Has any data been done in recent years? As more and more research has been done, how is that affecting people from carrying out their suicidal thoughts? Is there any data on that?
That's such a great question. It's like the ultimate question for suicide prevention researchers. It's the so what. So we're building towards something, we're moving towards something, but the so what. So the answer is it's really complicated. So in a study, you can show that something reduces. It's very difficult to use death by suicide as an endpoint in a study, because you don't want that as an endpoint in a study. And so you use other proxies like suicidal thoughts or suicide-related behavior. We can look at population-level changes in suicide rates. So in Canada, suicide rates have actually come down a little bit over the last decade. In China, they've come down pretty significantly. In some European countries, they've come down or stayed stable. In the US, they've actually come up a little bit. But it's very difficult to know what's causing what. And so the danger is you can kind of throw the baby out with the bathwater, because if one of the big stressors is, unemployment in rural communities and opioid use, but we're doing more suicide prevention care for depression, on a big scale, you kind of wash out the results. So stay tuned, I guess. But one thing that does have evidence actually is a national suicide prevention strategy. So we published a paper showing the potential sort of save loss of life if we have a national suicide prevention strategy that incorporates like X, Y, Z in a really systematic way. So I think that is the last question. Yep. Thank you so much.
Am I on? Oh. Am I on? Okay, sorry. I just wanted to say thank you very, very briefly to Dr. Zaheer for a thoughtful and thought-provoking discussion. I also apologize for not introducing you as a fellow alumna from the beginning. What a miss on alumni reunion weekend, but thank you for including that. And most importantly, just from a personal perspective, I think we all have personal thoughts and feelings about this that will take some reflection. Thank you for deconstructing what can seem as a very overwhelming topic into sort of the practical what, why, and how. And thank you for the optimism and the hope and framing the discussion really around every life being worth living. So thank you very much for joining us, and thank you everybody here and online, and hopefully you enjoy the rest of Alumni Weekend.